Welcome to Rev MD, a podcast created for healthcare professionals by healthcare professionals. We will share tips on medical billing and coding, as well as workflow optimization to help practices succeed, thrive, and grow revenue. All right, last week we talked about chronic care management, or CCM. As a refresher, this is the service performed in our offices utilizing that non-face-to-face appointments, right, to help manage patients who have chronic illnesses, which is defined as 2 or more chronic illnesses expected to last 12 months or longer or until death, and that place the patient at significant risk of death, acute exacerbation or decompensation, or functional decline. So this week, we're actually going to talk about a similar program called Principal Care Management, or PCM. And this is just another transformative care service for your patients with chronic conditions. And because both are very similar and it's easy to confuse them, we know that it's important to have these topics be back to back so you can compare and contrast and figure out which patients qualify for CCM services and which qualify for PCM services. PCM is slightly different than CCM because these patients only need to have one single high-risk or complex condition that's expected to last 3 months to 1 year or until the patient's death. Now, 6 out of 10 Americans have at least one chronic disease, and 4 out of 10 have more than one chronic disease. So we all know that chronic care condition accounts for a large portion of our healthcare spending in the U.S., and that is why it's so important to manage these patients differently, but also to get paid while you're doing it, right? The end goal of PCM is slightly different, right? Because there's a concrete time frame we're working with. So the goal for PCM is to stabilize the adverse condition so that then the patient can return to their regular primary care visits without the condition being that sole focus. Now, CCM seeks to work in tandem with primary care for a longer period of time. In regard to building in time into workflows, the difference between billing for PCM and CCM is just about 10 minutes. So PCM requires 30 minutes minimum per month of non-face-to-face clinician time or clinical staff time, while CCM requires a minimum of 20 minutes. Now, remember, you're still creating a care plan just like with CCM, and so we'll review some of those elements of a care plan to help you implement. Now, that care plan can include things like both medical and psychosocial issues. You're always going to be encouraging preventative care during that period of time. You're dealing with medication reconciliation. You're also managing and promoting that patient to take action for their own care. The revision of care plans is also important to consider because just like when we enroll a patient in CCM and you create that care plan, with PCM, you're going to do the same thing, and it's going to still require that constant revision of the care plan and input from any specialty physicians that are acting as part of that care team. Now, a CCM care plan sometimes doesn't need to be revised as often as a PCM, which generally has to deal with the chronic condition's trajectory and how long that chronic condition is typically lasting. Along the same lines, the PCM care plan must be disease-specific and outline actionable steps to tackle the specific issue, while CCM can sometimes be less specific because you're dealing with multiple chronic issues that are expected to last a longer period of time. Just like with CCM, elements of a care plan typically include things like a problem list, measurable treatment goals, the planned interventions, any sort of medication management, and of course, any interaction and coordination of care between other providers or other subspecialists. With PCM, you will need to go through the same evaluation and enrollment like in CCM during a face-to-face visit, but the billing codes and eligibility are again slightly different. You are also able to use a hybrid model, of course, where some of your patients qualify for PCM, some of them qualify for CCM, depending on that patient need, or transition a patient from PCM to CCM services if applicable. In 2021, there were new CPT codes added, which we'll talk about in a minute, for PCM services that are delivered by either a clinical staff or a physician. So the codes are 99424 and 99425, which are time that's spent specifically by a physician or other healthcare provider like a PA or an NP. And the 99424 is the first 30 minutes, because again, that's the minimum, whereas the 99425 is for that additional 30 minutes. And these codes actually reimbursed by Medicare over $80 or $60 respectively. We'll talk about revenue estimates in a few minutes. Now, the other codes are 99426 and 99427, which are for the clinical staff time. So similarly to the 99426, is for that first 30 minutes, and the 99427 is for that additional 30 minutes that you use on top of that. It's important to note that PCM can also be billed alongside remote patient monitoring, or also RPM, which we'll talk about next week. So practices should take that into account for any staff members that need to organize, analyze, or interpret data. And also remember that patients cannot be billed for both CCM and PCM during the same month for the same patient, which makes sense, right? So the decision to hire new staff for CCM or PCM is going to depend on how many patients are in the practice and what you estimate the amount of time needed for each of those patients. Is it the minimum, the 20 minutes or the 30 minutes, or are you expecting much longer time? And that's why sometimes it's just best to find your eligible patients, maybe start with CCM, because the reimbursement is better than PCM, and you're going to be dealing with those higher risk patients who need the help more. And then start as a pilot, identify and enroll the first 10 patients, 20 patients, and then you can start to get a feel for the workflow and how you're going to implement. Now, a smaller practice may choose to assign existing staff to coordinate PCM or CCM services, whereas a larger practice may need to hire someone full-time. And remember, these people don't have to be in your office. They could be remote and managing these patients remotely. So it's important to think about what would these individuals be doing in your office? How are they coordinating care with either PCM, RCM services, RPM services? And could they be helping make sure that all of your patients are scheduled for their annual wellness visits? Again, multiple opportunities for these individuals to help grow your revenue. So just like in last week's episode, the process of implementing CCM is the same for PCM. So you're going to want to first identify those patients who are eligible. Again, for PCM, you're looking for patients with one complex chronic condition expected to last 3 months up to at least a year or until death of the patient. And that issue is going to be the focus of the care plan. The condition also has to have sufficient severity to place the patient at risk for any hospitalization, or maybe it was the cause of a recent hospitalization, or it puts the patient at significant risk of death or acute exacerbation or decomposition or functional decline. So the condition also requires development and revision of, again, that care plan. So you're going to want to say, okay, this patient has this chronic condition. It's expected to last 3 to 12 months. And now we're going to manage that chronic condition through the care plan. And that care plan, again, with PCM is going to be more often revised than, say, something or a patient that's managing CCM services. And so you'll want to make sure that you're doing that, documenting those changes in the care plan, whether that's medications or any other sort of psychosocial or medical conditions. So once you've identified those eligible patients, you're going to want to spend some time looking at volume and revenue expectations. You're going to want to map out your workflows just like you did with CCM in order to figure out how you're going to manage these patients. If you're struggling with this workflow, certainly reach out. We have some sample workflows to kind of give you an idea of step 1, step 2, step 3. And you can email us at info@nationalrevenueconsulting.com. So let's give an example of revenue. And I didn't do this in CCM, and I probably should post this or send out an email in regards to this, because I think it's important for you to go through this process. So for PCM, say you have 250 patients that qualify. Say you're just billing that 99426, right? So that's that minimum 30 minutes of clinical staff time, not physician time. And you're getting a roughly $60 per patient per month. That's about $15,000 in revenue a month. Now, say you take into account a single staff member is managing those patients. Say you pay them $50,000 a month, a year, then you're still capturing well over six figures in annual net profit, well over $100,000. And the time spent on each patient is, again, that 30 minutes. Say that you're just doing that minimum per patient, which equates to about 125 hours per month for those 250 patients. So as with CCM, the patients will need to be enrolled into the PCM program. Like I said, in that face-to-face visit, you're really going to want to make sure you have documentation down and you're putting that enrollment in the EMR, you're putting the care plan in the EMR, you're revising the care plan. And then once you've spent at least that 30 minutes over the course of the month, you're also documenting that and sorting out how you're going to bill for it. So just like the clinical workflow is important, the billing workflow is also important. So you're capturing all of those codes. Just like with CCM, these patients are also going to have that 24/7 access to staff so that you can manage any issues that come up and also any care transitions, say from a hospital or an emergency room visit, as part of that care transition planning. Now, some EMRs allow you to document visit by visit to document, hey, I spent 5 minutes today, I spent 5 minutes later this week, or 5 minutes next week, so that you can add up that time throughout the month. One of our partners, which is RxNT, which is a software EMR platform that we have really begun to love, offers this as part of their solution. Now, we do not get paid or reimbursed for our clients who use them, but we have found it to be a really excellent solution. And it is one of our preferred options for billing software if a practice does not have their own billing software in their EMR. So we'll want to follow denials for this. And again, we'll talk in a couple weeks about metrics and how you manage denials and how you follow up with those. But specifically denials around PCM or CCM services, as you implement this program, you're going to want to keep an eye on. You should have much less than 5% of denials, with some offices getting down to 0%. But if you are seeing denials and you are seeing a high percentage, it's important to sit down and figure out why. So that ends our discussion around PCM this week, and hopefully you found this helpful. Last week, I'm excited to announce that we hit over 1,000 downloads for our podcast, and that's just been a little over 6 weeks. And so I just want to say I'm really humbled by the number of emails and folks who have been in contact with us. We're just really excited to help, which is really the reason why we started this company. So this month, we're actually running a special, which I talked about last week, where new billing clients who sign up by the end of the month get CCM and PCM services bundled as part of their contract, meaning we'll help you implement, we'll help you with the workflows, and make sure that everything's running smoothly. It's important to note that some companies will actually charge up to 40% of the collected PCM, CCM revenue to implement these services. If you're thinking about making a change with your billers, or say maybe you're not quite ready yet to make a change, totally okay. We're always here to help. And if you want, schedule a call with us just to go over your billing metrics so maybe we can see where you may have opportunity and help identify those for you. We are working on a special billing metric mastermind in July, and so more to come on this. That will be an opportunity for us to go over metrics, go over benchmarks, how to develop KPIs, and also an opportunity for you to even bring your metrics to the discussion so we can have an opportunity to go over where you may have opportunity specifically in your practice. So as always, visit us at nationalrevenueconsulting.com or email questions at info@nationalrevenueconsulting.com.